Hello and welcome. I am here with Dr. Danielle Joyce, here to share her experience as a physical therapist. Danielle, how are you doing today?
I'm doing well. Thanks for having me.
Awesome. So can you tell us a little bit about what you do and how you got there, and specifically what kind of people might be needing your type of help?
All right, I'm a physical therapist. I graduated with a doctorate in physical therapy in 2010 from the University of Washington, and I've practiced since then in a outpatient, mainly orthopedic setting. So someone that would they have to be able to drive into the clinic. We would get people injured maybe in car accidents or sports-related accidents or work, or just, we had a wide range of people, high schoolers spraining an ankle to someone that's getting older and is at fall risk and has to work on balance. So a very wide range of people need this. Specific to this podcast, there was a wide range of people that would qualify as perhaps persistent pain that has lasted over 3 to 6 months, is not really correlated to a specific injury, or maybe just has had over years, had flare-ups, never completely gone away. And that is an area that we'll probably go into more detail here, but I didn't feel as prepared with my education to handle that. I felt like we were very much taught this kind of narrow biomedical model of, this is the injury at the tissue, this is the time frame that it will heal, these are the maybe stretches or exercises or soft tissue mobilization to work on that. We also learned, these are gait and balance exercises, but the population, which is 1 in every 3 to 4 Americans, over 100 million Americans, last time I checked, have some form of chronic or persistent pain. And as I continued to practice in that type of setting, I realized that I wasn't doing a very good job with those patients, and I didn't feel very prepared. So I have kind of, with my own continuing education, learned more about that, and the science of that is really, I think, has grown leaps and bounds from even when I graduated. So I hope at this point, actually, a current physical therapy student might be receiving more updated and just more information on that. But
More understanding on some of the underlying issues rather than just the acute physical symptoms.
Yeah, and just, you would treat someone that comes in your clinic with acute back pain that they, got from straining to lift 2 weeks ago differently from someone with back pain that comes in that has had it for the last 5 years, and we learned, obviously that's not the same, but I think my training really, we learned about the biopsychosocial model. I don't know if they're still using that, these kind of 3 circles of Venn diagrams of how any type of injury, you have kind of a conglomeration of all of those, but I felt like my education was very heavy on the biological model, and kind of just, you can kind of figure out the psychosocial, or those were other disciplines that don't necessarily need to be addressed in physical therapy, because that, the name physical therapy, I think we definitely focused on the physical, and the more I practiced, the more I realized, a lot of these patients, the symptoms may be physical, but the underlying issue or drivers of the pain are so much bigger than that. And when is it appropriate for us to address that, and when do we need to maybe, have them go and focus with other providers first?
I think it's probably one of the unfortunate side effects of the scientific revolution that happened a few hundred years ago, where there's been such a focus on the physical side of things that it feels like it's almost to the exclusion of all else.
Yeah, and
at least up until recent decades.
Yeah. That model has done works and bounds for lots of things, diseases, or cancer and our reaction to COVID and things like that. Science has done great things, but I think we can't put everything under that microscope. Not everything reacts or heals with that model exclusively. We have to include other aspects to our care, and especially in persistent pain. So actually, I've heard the term chronic pain, so those terms are somewhat interchangeable. The education that I got more recently, we used the term persistent pain, but if you've heard chronic pain and you're like, oh, is that a different thing? I would just say we could use them. I'm using them interchangeably. They're not different.
Awesome. And I would love to go into that further with you a little bit later in the podcast. So, but where did you start out? What turned you onto the path of being a physical therapist? And then kind of what steps did that journey take to get you to the place you are today?
I mean, I don't have this great story of, I knew I wanted to be a physical therapist for a while, but it started out very simply. I don't know if I knew exactly what I was getting myself into. I was an active, child with sports. I had knee injuries. I went to physical therapy. I thought like, oh, this is kind of cool. It's a relaxed environment. You get all of these like, toys to, there's a trampoline you can throw a ball against and weights. And I just was interested in how the human body worked. It is a, medical field, but it's not as high stakes as, cutting into someone. It's like, okay, it's a little more chill. So a lot of those aspects of it appealed to me. Yeah, and then as I went further in my education, I volunteered in a number of physical therapy settings to kind of just check to see, is this, still what I'm interested in? And so I just kind of followed that through my degree. And then once I started practicing, realized there was, a lot more to it. But yeah, I mean, it's amazing because you'll never get bored with the job. It's not just, you definitely don't do the same thing every day. You can see this, almost the same exact injury in two different patients, and they might present very differently, recover very differently. So, yeah, it's pretty
That's
fascinating.
interesting. It's interesting. What would some of the things be that might differentiate between, because this goes into what you were saying earlier with some of the underlying issues or some of the things you might treat them differently. Someone has the same exact injury, but like you said, they either need a different path of treatment or maybe a different underlying cause. Like what kind of showed you that there's a difference between these two, and how might you track that down?
Hard to separate that from my continuing learning, because I know there's, several categories that might predispose someone to develop persistent or chronic pain. I mean, the ones that I noticed before I started kind of delving into the research, and that was kind of commonly known amongst healthcare professionals specifically, were like, well, I don't know if that, I practice in Washington. I'm not sure if this is a term that applies to all states, but we called work-related injuries were often L&I, labor and industry. So if you got injured on the job, often, it's a bit of a stereotype, those injuries would persist much longer and take much longer to heal. And I think it's because of context, especially because, often those work-related injuries then prevent the person going back to that job. They were often, kind of physical labor type of jobs. You've been doing this for years. You hurt your shoulder. You're no longer able to do the piping or electrical work overhead. And then there's life stressors. Sorry, you're not able to get the money that you got for your job. You don't know what else you can do. There's a lot of emotional, psychological overlay, and not deliberate by any means, but those type of things increase stress in your body, cortisol, that then, affects the immune system, prevents healing, and it's just kind of a whole cascade of things. So that was when I saw often that it's like work-related type injuries, especially if it is an injury that prevents the person from continuing in their work. Anything with claims, honestly, a work claim or a motor vehicle accident. Motor vehicle accidents, another one. It's like, because there's stressors of, now I'm down one car, now I have to figure out whose insurance is going to cover this, and that motor vehicle accidents are often traumatic too. It's scary. So the context in which it
fascinating
happens,
because, like you said, it's something that people think physical therapy, this is physical, but you're bringing in some things that, when you mention them, it seems obvious, but that is like a non-physical element of the physical healing, that the stress of the incident or the stress of the situation that they're going through while they're healing, or the context of the injury, all of that, how that affects the healing. Even though this is physical therapy, all of these things actually pour into how well the physical therapy is actually able to work in the person.
Definitely. So yeah, actually an interesting study that related to car accidents and whiplash disorder or neck injuries post motor vehicle accident. And I don't, if anyone's listening and struggles from that, I don't mean to like minimize your pain or your journey at all like that, because hopefully we'll get to it later. But pain, no one wants to hear it's all in your head, but like pain is a perception by the brain that's very complex, and we used to think if we said it's all in your head that meant you're making it up or you're malingering, and that is not the case whatsoever. But there was a study on what do they call them, derby car drivers, so people that drive beat up cars and kind of just crash them for fun, honestly. And they looked at 20 or 30 drivers that did this over a number of years. They calculated the number of crashes they were in, the speed of the crashes that they were in. I mean, they drive for a couple hours a night and get in multiple accidents. And then they asked them to report, if they had any serious neck injuries and things like that. And some of them did, but it was at a significantly lower rate that you would get from people that were in a motor vehicle accident at the same velocity as just out on the roads. And it's like, so the physical totally aspect of the accident would have been the same, but the context, these people were out there doing this for fun, right? It was a positive environment versus, you get hit in the intersection and it's terrifying, and now you have this claim and you don't know what to do. So there's lots of studies and incidents like that just are interesting. It goes to show how complicated a pain perception is, and there's a lot of subconscious aspects of it that we don't always take into account.
Yes, I was talking with my chiropractor just a couple weeks ago, and he was kind of sharing with me a little bit about what you're talking about, how when you say, like you said, it's all in your head, that doesn't mean you're making up. It means, as far as the wiring literally in your physiology in your body about the nervous system and what your body registers as what should be painful versus what is painful, all of that. You often feel the pain before you actually ever approach a real injury, because your body's protecting itself from that. And it sounds like what you're saying is when there's stress involved, when there's fear involved, when there's this like traumatic circumstance involved, then the body registers a much higher level of pain, or I should say a much higher level of fear, of stress, of all of that, and so tightens up even further to prevent that pain. Does that relevant to what you're talking about?
Yeah, I mean, pain there's no like one pain center in our brain. There's multiple areas that light up and give us a response, and pain is basically a response to threat. It tries to protect us from things. So the more of a threatening situation we're in, the more it will, trigger. It's kind of a cycle, that pain response. So if our body perceives threat, it's going to sound the alarm to protect us. So Yeah, you can think of it kind of as an oversimplified example, but I've heard it in pain education scenarios of pain being like a smoke detector in your house. You know, you want that smoke detector to go off if there's a big fire to say, you know, you're in danger, get out of the house. Or if for your body, like, oh, my shoulder's up here, like, get it down. It could, if we keep going, it could damage it. But in certain chronic or persistent pain, that smoke detector gets oversensitized. So maybe you like light a match in another room and all of a sudden it's just like, It doesn't, it's not in proportion to the level of the threat necessarily. But that's a common misperception of pain, misconception of pain, is that if I have a lot of pain, it must be a really bad injury. And in acute, sometimes that's more reliable, but especially in pain that has persisted more than 3 to 6 months where the tissue generally heals, that is not a consistent measure of it. Someone can be in very bad pain without any damage, but their body is very sensitive and it's still perceiving a very large threat.
That kind of goes into something you alluded to earlier. I think in your journey, I remember from previous conversation, there was kind of a point where you realized that there's more going on than just this one dimension, and how in your care you started to look outside into different lanes and how all these different things are connected. It's not just the biophysical model that you were taught, but there's other things that you can bring in to improve your client's care. Would you mind talking about what led you to that realization and what was the path that you took forward?
I mean, I think multiple things led me to that realization, but the path I took forward was that I kind of pursued continuing education in this area within the scope of physical therapy. But I took a 6 months program to get credentialed as a therapeutic pain specialist. And that focused a lot on pain neuroscience education and how to kind of explain this to the patient. Because it's actually been shown that, I mean, probably not every single patient, but in general, when you explain to someone that's had chronic pain, some of these things we've talked about, how pain is not actually a good indicator of the damage of the tissue, but is more of just a response to a perceived threat. That understanding, I mean, I'm oversimplifying it. Perhaps this will take 2 or 3 sessions to explain to them but understanding the science of pain and that, you know, just because it hurts doesn't mean you're continuing to push into an injury, can kind of calm down the nervous system a little bit and, you know, decrease their pain a little bit over time. So, you know, a lot of physical therapy and therapists that have this training now, it's a big piece of how they handle this patient population, is making sure that they understand the science of pain rather than continuing to think, oh yeah, like this back pain that I've had for 6 years that's debilitating, it's because I have a bulging disc. And if I push through it and move, this bulging disc is just going to get worse. It's like, that may have been what they had initially, or that may be what they've been told in our biomedical model. But what we know about pain science education, you know, that's likely not the case. And so if a patient thinks it's a biomedical problem, that is going to be the treatment that they pursue. If they think that it's a sensitive, nervous system or brain perception problem, then they might be more open to pursuing options that go that route. For example, you know, mindfulness or meditation has been shown, and I think you've probably talked to other providers that are much more, have much more information on that, or breath work or things like that, that just tap into our nervous system or perhaps calm the system down can have a great effect on minimizing or lowering the levels of persistent pain in someone. And if the problem with persistent pain was a bulge in the low back, how would that explain why 10 minutes of mindfulness would decrease the pain, or breath work would do that? So I think having patients understand what persistent pain actually is will help them in their own journey. It'll help decrease the fear that they might have of movement and worsening it, but it'll also help them maybe pursue other forms of treatment to calm their system down, and help them on their road to healing.
It's interesting. It's somewhat analogous, or my story might be somewhat analogous. I have a background both in the military and in martial arts, and in both of those situations, in combat, well, in either of those situations, one of the first things that you have to learn is how to remain calm in order to move forward. And it really is a very similar thing. What you're describing is that the fear response to the anticipation of pain is often what people feel most, and is often what people are affected by the most, whether or not they're injured. Many times even before they're injured. And in combat, it has a lot to do with being able to keep your head and being able to keep your calm while you focus on the job at hand, whether that's in the ring or in the battlefield or whatever. And so it sounds like it's what you're doing is you're kind of helping people do the same thing in your practice, where they are feeling this pain, this stress, this tension, this thing that they're interpreting as injury, and maybe there's an injury there, maybe not, but what you're helping them do is to kind of re-understand what's going on and kind of keep their cool in the middle of this pain so that they can move forward in an advantageous way. Does that kind of ring true with you?
Yeah, I mean, because pain is a perception that our brain makes based on its threat level. So if there's anything that you can do and I think that understanding how pain works hopefully decreases that threat level, but there might be other aspects of the therapy too that, understanding, maybe doing exercises in a certain context might trigger anxiety. So you won't want that patient to do the exercises there. You want anything that you can do to calm the nervous system or decrease the threat level will be beneficial to people with persistent pain. So yeah, there was one education class I took that they talked about DIMS and SIMS. So DIMS would be danger in me, or safety in me is SIMS. So there's lots of things that and it's unique to every person, that they might, if someone was in a car accident, a certain intersection or maybe that morning they went to the gym and then they associate that with pain, and so having them go back to the gym to exercise for the recovery, they might not be ready yet. But, safety, maybe they feel safe in their home because that isn't associated with where their injury happened or something. So, you want to figure out the context, environmental, emotional, socially, all of these things to make them feel comfortable to begin their healing journey. And a lot of this, you really, as a practitioner, you have to get to know your patient and ask pointed questions. But I would say for someone that is pursuing physical therapy, you have to advocate for yourself too. We're the experts in maybe exercise, functional activities, the physiology, but we're not the experts on our patients. And sometimes it's like I'll see a patient 6 or 8 sessions and then they'll bring something up from home or something, and it's like, oh my gosh, I didn't know that. Like, I wouldn't have told you to do this had I known that up front. But I think sometimes people go and seek medical advice and they just think, okay, they're the experts, they'll tell me what to do, where maybe they don't feel comfortable doing the exercises as we prescribed or things. And it's especially in those persistent chronic pain type of settings, you need to advocate for yourself and tell us if you don't feel comfortable, then that's not helping kind of, in this healing journey.
That's such an important point, and what my wife calls a quotable quote, like the thing that you'd want like a little poster board and put that up. That the idea that the provider may be the expert in their field, but the individual is the expert on their own self.
Mm-hmm.
And understanding the difference between those two things, because we do definitely live in a culture, in a society where we're kind of taught to give all of the authority, all of the say-so, all of the everything over to the doctor, the person
Mm-hmm.
who's behind the desk and wearing the white coat and all of that. And we kind of just set our brains aside and, okay, doctor, you tell me everything and I'll just go do what you say and everything should get better. When, like you say, no one is the expert on your life but you.
Mm-hmm.
And understanding how to advocate for that. And in both in our culture and in the military culture that I was in for a long time, you're kind of taught to just like shut up and do what you're told when it comes to these people are the experts. But like you said, learning to balance that, learning to be a good patient in a way, learning to seek the care that you need regardless of where it's found, like is immensely important. I'm glad that you brought that up. In line with that, do you have any stories of perhaps where someone came to you and they were pursuing your type of care, but you actually realized they might have needed a care in maybe another sphere of their life before they came to you in an effective way, or vice versa, where they were pursuing something else and you realized they actually needed to start with something more physical therapy before they moved forward with that? Is there anything stories that stand out, that type of thing?
I mean, probably the most common would be patients that come to physical therapy, but I think either in conjunction or even before we start, they would benefit from some type of mental health professional or counseling, or just either, unaddressed stress or trauma, or that can definitely get in the way of starting or being consistent with physical therapy. And I mean, sometimes honestly, I've had patients where it's like, I think if that's addressed, the reason for needing physical therapy would almost completely go away. So, okay, sorry, your connection is blurring a little bit. I didn't know if you can still hear me.
Yep, we're still good.
Okay. I mean, so actually this is kind of a funny example I saw years ago. He's probably a young man. Well, it makes me feel old. He's probably in his 20s, I don't know. And I'd seen him for maybe 6 or so sessions for knee pain. I can't remember if there was a specific injury or what, but we tried several things. Usually at this point, someone of his demographic and that type of injury, you would see some improvement. We'd kind of, it kind of had stayed the same, nothing significant. So I'm kind of thinking like, what's going on? I didn't ask many questions about his, environment or life stressors or anything like that. I was just, new grad, kind of focused on the knee pain and going like, why isn't anything happening? And then he came back for, his next session, 7th or 8th, and it was significantly better. It's like we'd done all these things, stayed the same, and then it was like next time I asked him how he's doing. Oh, so much better. It's like, oh, okay. So what, the exercises, I'm asking what happened. His response was that he got a puppy. And he got a new dog. That was the only thing that was different. And it was
That's awesome.
I mean, it's kind of funny, but it's like, okay, so maybe this guy, maybe he just was, I can't go into the specifics, but obviously that was something that needed to maybe break him out of whatever, if he was lonely or mild depression or needed a distraction, or I don't know, but I think I saw him one more time after that, and it was discharged him because it was better. It's like, okay, you know.
It's amazing. I think joy specifically has such a power to be able to overcome pain. And I think that's partially why kids are so bouncy. Like they get hurt, they go crying, and they go back to playing, and it is as if nothing happened. And I think it's definitely something we can learn as adults, is the power of just having the simple joy in your healing journey. And it sounds like he found that through puppies.
Yeah. She's like, okay. I went to school for you know, 4 undergrad and 3 postgrad, 7 years, so that a puppy could put me out of my job. No. But no, I was happy for him. But yeah, that was the most dramatic. I've had a few. I don't specialize in it, but CRPS. Are you familiar with that? Chronic regional pain syndrome. It's really interesting, and there's been a few times I probably missed it, but it often affects an entire limb or a hand or a foot, and it's just this very intense pain, often inflammatory response. You can see kind of sometimes trophic or skin changes. The 2 that was diagnosed and that I saw were actually 2 younger men. One was probably grade school, and then another was maybe 18 or something after a knee surgery. And it's just the pain is totally out of alignment with any type. Sometimes there's an underlying injury, sometimes there's not, but it's very intense pain. And it can be very hard to do therapy with any type of traditional therapy because they get, you know, so painful. I mean, you have them do 10 reps of this and they're just in excruciating pain. So I would like to say, you know, I treated them well. I don't think that's necessarily the case. I didn't have the, you know, I tried different things to think outside the box. I didn't have the training to do some of what, you know, an expert would do in that. But both of those strike me because I maybe saw them 6 to 12 times or over the course of months. And again, it's like several times, and then it's like overnight something clicked and they came back with, you know, almost back to normal or significant improvements. So again, that points to the contributions or outputs from the brain, and it wasn't a conscious decision on their part. I'm not saying that at all, but sometimes you can get something, or in instances of that, where, you know, somehow their brain just flips a switch and doesn't perceive it as a threat anymore, and they come back and they're able to, you know, walk. The elementary school kid that I saw, I think he sprained, actually now that I think about it, I think he sprained his ankle in soccer or something like that. Mild sprain. Usually a kid that age will just pop back within a few weeks, get back to their normal activities, but his progressed and got so sore that he couldn't even weight bear on it. There was no, they did, you know, all of the imaging and stuff to make sure there wasn't ligament or the bone damage, but it just turned into this CRPS. And we, you know, couldn't really make it much gains with the traditional therapy. And then, you know, he came back one day and it was almost completely better. So yeah, so things like that, it led me to think this isn't all physical healing of the tissues. This isn't all the biomedical, you know, what's going on with imaging and things like that, that pain and our body's reaction to it is very multi-dimensional.
I like to think of it in some cases as being like the neurological wiring, where there's like a network of conclusions that need to be drawn in order to kind of set the stage for that final connection, where the brain learns something important, and in this case learns that, oh, this is no longer a threat, I can move forward. And a lot of times, especially you see this in like psychological therapy work, where it'll take a ton of groundwork just in order to teach the person's brain, or like wire the person's brain in a way that it can reach that final conclusion, which then seems like it's overnight. And it sounds like it's something similar, or in some cases it might be something similar, where there's a neurological thing going on that affects the person's body in this pain perception type of way that you're talking about.
Yeah, and actually, I don't want to. There are instances of that. I would say, by and large, with persistent or chronic pain, it's. You talked about the wiring. They say, you know, nerves that fire together wire together. So, you know, if your body is sending you these signals of pain, chronic back pain for 10 years, you're probably not going to get that fix overnight. You have to retrain the brain, or they say that nerves that fire apart depart. So you have to, you know, figure out how to decrease the threat level, maybe do some safe movements, and gradually over time, you don't usually get that overnight. But, you know, there are instances of it that kind of show, you know, that this is not just a tissue issue. Wow, I'm doing a lot of rhyming here.
A lot of alliteration going on. Yeah, one example.
Yeah,
this isn't a physical therapy necessarily example, but an example of those like nerves that fire together, wire together. In my childhood, I dealt with some loneliness, and I was a pretty lonely child in that time. And one of the things that I turned to was food. In kind of, it was my like loneliness and boredom and all of that, and I turned to food in order to kind of medicate that. But then in my adult life, what I noticed was that I was like hungry all the time, and I couldn't figure out why. And it wasn't until like some therapy and like working through some things that I realized that my body was interpreting hunger when actually what was going on was loneliness or boredom. And it's because these two completely separate parts of the brains had been firing together, and they wired together. And part of my like healing work had to do with like breaking that wiring and like making new pathways. But two completely separate parts of the brain, as far as I know, I'm not a neurologist, but two separate parts of the brain that fired together and then suddenly wired, and now one felt like the other.
Yeah, it is interesting how our brain works, because like there obviously there isn't one center of our brain that perceives like pain or physical pain or trauma or any of these things. It's, you know, different aspects. And I heard the analogy, like if you ask someone to think about their grandma, let's say that they had a good relationship with their grandma or something, so you might think of the house that she lived in when you grew up, or you might think of the chair that she sat in. You might think of the smell of the cinnamon rolls that she made, or the, you know, if you see someone with the hair the length of, you know, there's, or that your song, if any of those things come on, it might trigger your brain to your grandma, because they're all different things. But, you know, pain, or in your case, hunger, there might be all of these links to that and gets your that physical response from your body. Well, something I find interesting that might be helpful for people's perception or understanding of pain that I didn't talk about, the phantom limb pain and like mirror therapy. I don't know if you're familiar with that, but
I am. Yeah, there's some amazing work there. Yeah,
but yeah, how you can have, I mean, that shows that pain is perceived in our brain, right? Because someone that has lost a limb, or, you know, below knee amputee, perhaps has this excruciating pain in their foot, but their foot's not there. So, and then, you know, so you have to learn to retrain and rewire those, because the connections for where that foot is, you know, is still in the brain. They're still perceiving that pain, but clearly, you know, that's demonstrative that it's not a tissue model by itself, because, you know, their foot is gone. So I find that fascinating, and how they'll do like mirror therapy, where they're looking at the limb that's there and moving that limb in the mirror to trick their brain into thinking it's the other one, so that they can get some pain-free movement. And over time, kind of recalibrate their brain so that they're not in this, excruciating pain. So
that's awesome. It's amazing that they discovered that. So let's say someone is struggling today, and someone is dealing with some pain today, whether chronic or acute, but they're unsure what to do or how to move forward. What would be like the first 3 steps if you met someone on the street and they shared with you about they were in certain sort of pain that you thought might be relevant to your field? What would be like the first 3 steps you would say to kind of get started on their healing journey?
Okay, so yeah, first I would want to know, are they appropriate for my field? Because sometimes they're like, maybe no, maybe you actually need to see a counselor or a spiritual advisor or a mental health specialist, or maybe you need to see a doctor, a surgeon. But if it's someone that's like, okay, no, this sounds like it's really relevant to my field. I mean, practically, depending on the state you live in and your insurance, you might have to go see your doctor and ask for a referral for physical therapy to get it covered. So after we cover all those bases, I would, want them to have an understanding of physical therapy and correct expectations that, there's 168 hours in a week. I think you're going to be in physical therapy for maybe 1 or 2. Do you have the time in your life now to devote to, putting these things into action in your own life? Because I think that some more when I started out, but some people still have this perception of it as a passive therapy. I go, the therapist does some things or maybe manipulates my leg and I feel better. But especially with the more persistent ones, it's like I'm more of a coach, and then we talk about things. We might do some things in the clinic. I want to make sure you understand. I might put my hands on you and physically do something, but that's a very small part of the treatment. Like you are going to have to put a lot of these things into application in your own life. So if you're a full-time mom, caring for your grandma, and you never have any time to yourself, like, are you going to be able to, if I advise 20 or 30 minutes a day of aerobic exercise to help calm your nervous system, are you practically going to be able to do that? So because I see people sometimes that are very well meaning, they want to get better, but then I asked them to do things and they come back a week later and it was like, oh yeah, I didn't have time to do that. It's like, well, this might not be the time for you to do physical therapy then, because we can't, in 2 hours a week, probably short of a very narrow range of injuries, it's probably not going to be that helpful for you. So I think that's a big one of being able to commit some time to your, let's call it physical health. We've talked a lot about how it's really more than that, but in my practice, we're still going to be giving you, I guess, prescribing you more or less physical treatments. So yeah, do you have time? And I think another one is like, do you think this will be helpful? Does the person have this, I guess if they go in thinking, oh, I'm doing this because I know it'll be good for me, but I don't think it'll really work. There's not much we can do to help. So they have to have the time available and the belief, I think, if they really want to see some improvements. And then if they have that motivation, then I think, it's a good time to start physical therapy.
So what about someone who wants to be a physical therapist? What advice might you give someone starting off on their career or looking at this career as some things to think about or some steps to take? What would you suggest?
I mean, physical therapy is such a big scope. I mean, because there's people that maybe they just specialize in sports medicine, and I mean, I would say there's still a big aspect probably of some of what we're talking about, but they might be treating more acute injuries and the biomedical model might apply more. Or maybe there's people that are just working in a skilled nursing facility and helping, and that's what they want to do, and they're kind of helping transfer, get people up and down or walk down the hall. So I guess, if you know what you want to specialize in, then great. You have to get a general education, but go that path. If you want to see a variety of things, just know that and maybe it's different now. It's 14 years since I graduated, but a lot of what you see or what you learn in your education, the anatomy and physiology, it's important. We use that, but there's a lot more at play, and don't graduate thinking that you're going to be the one, fixing that. Your patients are going to come and you're going to, stretch and pop and move. And if they don't get better, it's because you aren't knowledgeable enough and helping. I think as a new grad, often you feel like we should have a sense of responsibility for our patients, but we probably put a little too much of that on ourselves. If a patient doesn't get better, it's because we didn't get the right diagnosis or right treatment. Whereas I think we need to, as a practitioner, kind of see ourselves more on a level playing field, hold our patients maybe to a higher level of accountability, and of what they're able to do at home. Because the reality is most patients, like I talked about, they're not going to get better just by 2 hours of seeing us a week. So have some grace with yourself, continue to learn and understand, and then ask pointed questions of the patient. One of the things that I've learned, especially with the persistent pain population, of asking up front, because if they've had back pain for 10 years, chances are you're not the first. Well, you're not the first medical practitioner, you're not the first physical therapist they've seen too either, but just having the humility to ask, like, what have you tried in the past and what has worked for you? Because like we talked about, sometimes patients, they come to you as an expert and they'll just listen to you, or they don't want to go against what you say. But maybe you do. If you don't ask that question up front, maybe you do your whole assessment, you think, this works for most patients, I'm going to give it to them, and then they leave thinking, oh, well, they just told me the same thing that someone told me 5 years ago, and that didn't work, and they're never coming back again. So you really need to listen, ask questions, get to know your patients, and their environment, their, what's going to work for them. Don't think that you have all the answers. And there can sometimes, as a new practitioner, kind of have this insecurity of, like, okay, I just graduated, do I really know this? So trying to act like, I'm the professional, I know what I'm doing. If I ask too many questions, they're not gonna trust me. And it's like, no, just stand back, ask. You don't know what you don't know. So we're the experts, like I said, in some things, but I mean, even the acute population, you could be telling them something that works great in 95% of those conditions, but for that 5%, you need to know if this is something that isn't the right time, or isn't the right exercise, or isn't the right thing to do because of their other experiences.
So, importantly, how do you maintain your own health when I know you're a mom and you are a wife and you run your own, like you have a practice as a healer. How do you maintain your own health, physical, psychological, all of that stuff, with all of the stuff that you are carrying other people in? How do you maintain yourself?
Well, currently I'm actually not practicing. I have since I gave birth to my daughter 6 months ago. I have a 6-month-old and a 3-year-old. So a disclaimer here, I'm not currently practicing, but prior to her birth, I was practicing part-time for a company called Luna Physical Therapy, where we would actually, it's outpatient physical therapy that we would see in people's homes. So I would bring my treatment table and my bag of stuff and actually, you know, see the person, treat them in their home for a one-on-one session rather than them coming into a clinic. But yeah, I was thinking about this question. If you can work part-time, honestly, that's a great way to go. But I understand that that's not the case for a lot of people. And burnout is very high amongst medical professionals, especially I've noticed a trend that in the profession of physical therapy, that new grads will kind of go into these very fast-paced orthopedic clinics where you're expected to see a patient every 15, 20 minutes. You hand them off to an aide. You're seeing a lot of patients a day. And then the older, more experienced patients will find settings perhaps that is a little bit slower paced. So, but I think that you could work in those faster paced settings. I don't think it's the ideal model of care, but I think that understanding how to document efficiently, accurately, but quickly, or using the shortcuts built into a lot of the electronic medical records these days, they call it EMR. That's a huge thing. That can cause a lot of burnout if, you know, you're seeing all these patients, which is, you know, takes a lot of work and is draining, but then you're expected to document all this. If you can't do that quickly, then you're just spending your lunch, you're staying after, you're coming before, and your 8-hour workday just turned into a 10-hour workday. That can be really draining. So I'd say understanding whatever your clinic's, their model for documenting, and you want to capture everything you did, but you want to do it in a as quick or efficient way as possible. I personally have not learned to do that super well. They take too long, but I also work part-time, so it kind of balanced out a little bit. Another thing, I took a continuing education for mindfulness for healthcare professionals, and they talked about kind of, I think you would call it grounding techniques, or sometimes before, in between patients, of maybe stopping at the door. We saw patients in treatment rooms, so of maybe, you know, touching the door for a second, taking some deep breaths to kind of gather yourself, because who knows, maybe that patient before was just very maybe challenging, or had, you know, something that maybe increased your own stress levels. You don't want to carry that on to the next patient. So finding just little things in between to try to reset can be helpful. So a lot of times with physical therapy too, you have some flexibility in your schedule, because you are expected to see perhaps a certain number of patients per day, but it doesn't have to be 9 to 5. Like you can, so when I was working full time, sometimes I'd take a couple days a week and I would schedule an extra hour at lunch so that I could go for a run or a walk during my lunch break. They had a shower there. I could, and you know, get some time to reset, also get out in the middle of the day when it's sunny, because I lived in Seattle at the time. Up in the winter, you'd go to work in the dark, you'd leave in the dark, because they're very short days. So for me, that was very helpful. It's like I could get out when there's actually sunlight, and that for my mood and disposition was helpful. So those are some of the things that I think can maybe help keep people sane. Just knowing yourself too. You know, for me, I know that, you know, if I don't see sunlight all day, that brings my mood down. Or if I'm not physically active, that brings my mood down. So trying to figure out what is helpful to you and how you can incorporate that into a work day, I think.
Awesome. And I love that example of if you have a certain you have a certain requirement, but maybe you can find some flexibility within that requirement to be able to take care of yourself. And it's really like taking care of yourself being so important to avoid burnout, because we need people like you in the field. We need people who are like helping other people improve their lives. And if you burn out, then how many other people are being hurt as well? And it's your work is so important. So what might be some resources you would recommend to someone, whether to learn about physical therapy or to improve their own work at home with physical therapy? Or what are some resources that you found helpful, or your clients, or anything like that? What would you recommend?
I mean, I was thinking more of the patient that might have persistent or chronic pain, because often when I think of our healing journey, I guess I think of a little bit more complex than, I don't think someone that sprained their ankle a week ago is probably necessarily listening to this podcast on their healing journey. So things that I have pointed to patients that have perhaps have had several, episodes of pain that maybe has defied a specific diagnosis, or that they've seen multiple medical professionals and not gotten much relief. I recommend that they understand more about pain. Don't just take my word for it or one specific person, but there's a lot of growing scientific and medical research and evidence online. So I found recently, I was looking up, because actually I took this therapeutic pain specialization program several years ago, and at the time I listened to a podcast called Pain Reframed that I found very educational. I think it was aimed at the practitioner, but I think it would be helpful for a patient too. But that hasn't had any new entry since, I think, 3 or 4 years. There's a current one called the Healing Pain podcast by Joe Tatta, Tatta, and he's a physical therapist. And they have on professionals from, some of them are therapists, doctors, or other, kind of multidisciplinary, and they talk about multidisciplinary approaches to pain, and that's updated regularly. There's several of those. So that's called the Healing Pain podcast. There's a couple, actually the United States for some reason isn't quite as up to date on some of these, but like Australia and the United Kingdom, they have some public education platforms on this, and tamethebeast.org is the Australian one that you could go to, and it has a ton of references and resources on and aimed at the patient or the person struggling. I guess consumer is not a good term for it, but on understanding pain and how it is multidisciplinary. I like this one as a physical therapist because it's created by a physical therapist that was one of the founders, Dr. Lorimer Moseley, in kind of exploring the science of pain. So yeah, that's tamethebeast.org. And then there's one in Europe that's called Flippin' Pain, and it's a public health campaign to educate people on pain. Because there is, I think, this big misperception out there that pain is directly tied to tissue damage. And unfortunately, that then leads people to finding a treatment option or diagnosis related to the tissue. And there's a lot of, obviously our primary concern is getting the person better, but from the medical standpoint, there's a lot of money lost in unnecessary diagnoses or medication or things of that nature that, if we had a better understanding of pain, we could avoid those and go to other treatment options first that would probably be more beneficial.
That's awesome. Thank you so much. Well, this has been an amazing conversation, talking about just re-understanding pain, re-understanding how it works and how important that is for someone's healing journey, the complexities that are involved in why injuries turn chronic and why they persist, as you call them, and then talking about the multidimensionality and the multidisciplined necessity of the process of healing, like all of those things. It's been an amazing time. Thank you so much for spending your time with us and enlightening us on how pain works and how to get rid of it. Thank you so much.
Welcome. Yeah, thanks for having me. And yeah, it's exciting that you're putting together, just all of these different experts and opinions on how to help us on our healing journey. So thank you.